Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Community health assessments are a long-standing component of public health practice. After all, if you're going to protect and advance the health of a community, you need to identify the community's health status, health burdens, resources, and the like. The Affordable Care Act ushered in a new requirement for nonprofit hospitals that as part of providing benefits to their community, they must undertake a community health needs assessment every 3 years. Now, despite their similar sounding names, assessments conducted by public health agencies and by hospitals can actually be quite different, but they are both supposed to support the communities where they operate. So shouldn't they be aligned? How much concordance is there between community health assessments and hospital community health needs assessments? That's the topic of today's episode of A Health Podyssey. I'm here with Cory Cronin, Associate Professor in Ohio University's Department of Social and Public Health. Dr. Cronin and co-authors published a paper in the June 2024 issue of Health Affairs assessing Ohio's efforts to address community health needs through collaboration between nonprofit hospitals and local health departments. They found important areas of alignment around community needs, but also areas of difference that are worth exploring. We'll discuss Ohio's approach and the research findings about them in today's episode. Dr. Cronin, welcome to the program.
Hi, thanks so much for having me.
So this is a great area for analysis. We all say we want to help our communities be healthier places, but we have these two really quite different processes with different origins that are designed to do so. So I wonder if I gave such a brief introduction at the top of the show. Can you say a little bit more about hospital community needs assessments and the local health department community assessments that are conducted in Ohio where you did your work?
Thank you. And so I'll repeat some of what you said from the beginning, but this really stems from a long-standing conversation, even debate, around nonprofit hospitals in the United States. So just about 60% of hospital organizations in the United States are nonprofit and therefore are considered charitable organizations. For decades, there have been requirements on nonprofit hospitals that not every hospital has. Some of these are around the areas of community benefits, and a lot of this is handled through the federal government and the IRS. With the passage of the Affordable Care Act in 2010, one of the requirements was that hospitals would do community health needs assessments and corresponding implementation strategies every 3 years. And this is a thing that some hospitals did before. For other organizations, this was a new process. But Ohio's offering an interesting opportunity to consider these hospital community health needs assessments in light of public health. As you mentioned, in Ohio, public health departments are recently required to be accredited organizations. One part of this accreditation are community health assessments themselves. And what Ohio's done is taken the opportunity of having these two different organizations doing a similar process to put them on the same timeline. And so they should be doing these assessments in accordance in the same every 3 years. This is a clear way to encourage these organizations to work together. Why would we need to assess the same community multiple times or from two very different perspectives? If we align the timing of these requirements, the hope is that these organizations will work together. And I think there's a lot of potential to this.
So that's a great description. So I really appreciate that opening explanation and the sense of potential here. Like we're all trying to do some of the same things. So at the outset, you have to ask when these two assessments occur, do they kind of find the same things? Do they say, yes, this community needs something, and the other entity does its work and says, yes, the community needs the same thing, or it says, actually, it needs something very different. You can't really align unless you start at the beginning with what you think the problem is. So what were some of the domains you were looking at when you were looking for alignment? I mean, what would it mean to have alignment?
That is exactly one of the questions our team was most interested in looking at this data of community health needs assessments and local health department assessments as well. And so one way that we approach what domains or areas of needs to look at is actually that our team's been working with hospital community health needs assessments for many years now and looking at a national level. From that work, about 17 items of health needs kind of rose as being some of the ones to show up more frequently in coding these PDF documents that are available publicly on websites. And so we look at a range of needs from things like social determinants of health to mental health, specific disease categories, asthma or diabetes, chronic disease generally. And we're really looking at these documents that are self-reported and put out by the organizations to understand which of these topics are coming up most frequently. The really rich data that's out there, kind of looking nationally, locally, or like we're doing here at a state level. And so the topic of alignment is interesting here because, as mentioned, while Ohio's making some changes to the timing of things to encourage local health departments and hospitals to collaborate on these documents, alignment is also at the center of this. And so the state of Ohio is looking for hospitals and local health departments to look at the state health assessment and look at the issues there as well and incorporate that into the documents that they're working with.
So you have a lot of history with the hospital side of this, and you describe, as you note, a range from fairly generic categories to specific diseases. When you set these two next to each other at the community level, just at the basic level, what do you find in terms of whether there is alignment or not?
Yes, in identifying health needs at a community level, and in this case, community, which is one interesting point of this conversation, is how do you define a community? It's actually part of the IRS regulations that hospitals would have some discussion in these documents about defining a community. For the purpose of this study and what we see generally is we're defining community as county. There's a lot of alignment when it comes to the top health needs coming from the hospital documents as well as from the health department documents. Mental health, substance use, obesity are the ones that are showing up over and over. This is also true when you look at the state documents that were produced in 2019. And it's also true, as I mentioned, we have a national sample of hospital community health needs assessments. And these are the same types of things that are showing up in a nationally representative sample of hospitals also.
So I'm hearing sort of at the highest level, these look like folks are looking at the same community, seeing the same dominant problems. But you did, of course, find instances where there was not as much alignment. And I wonder if you could just say a little bit, maybe even using some examples, or point us to sort of the logic or illogic might be a better word of why it is when these two different organizations are looking at the same community, they don't come up with the same thing.
Yeah, that's a really good question. And when you leave the top 4 or top 5 most common referenced areas of health needs, that's where we do start to see distinction and even see distinction by organization type. And so maybe not surprising, you see hospitals go in a more clinical direction. So you'll see hospitals looking at some of those disease-specific areas more, like heart disease, for example. On the health department side, one thing that's really interesting is health departments in our coding of these documents actually give a wider range overall than hospitals. They're likely to, in their documents, hit on more of these 17 items that we went in looking for than hospitals are. But they definitely show up in some areas that we might classically associate with public health. They show up with social determinants of health more often than hospital documents do. Preventative health care is an area that health departments seem to hit on more, or even areas like tobacco.
In the first instance, you'd say commonality, and then they start dividing along what might consider somewhat predictable lines. Hospitals focused on clinical services, as you note, public health looking at sort of traditional public health issues. That's not necessarily a problem. It's just sort of the perspective you're bringing to the table. But you also looked at the characteristics of hospitals and the characteristics of communities. And I'm curious about what kinds of communities or what kinds of hospitals are more likely to show alignment between these two parties and where they're more likely to diverge.
Yes, in this question of alignment is also an underlying question of process. And so I believe one of the things that the state of Ohio is looking to do is increase collaboration, conversations in these two areas that the state considers leaders of health for their community. Those are language that they use in talking about and promoting some of these new policies. And so one thing we looked at is a concept of formal collaboration. In our study, every hospital that we had some reference to getting input or considering local health departments in creating their community health needs assessment documents. This, in fact, is one part of the IRS regulations, is that they should be hearing community voice, working with local state authorities in doing this. And so that was universal, that there was some reference in the document of hearing from or getting input from local health departments. However, about a quarter of our sample directly referenced a process of formal collaboration in creating this document with their local health department. And again, probably not surprising, but good to have kind of a confirming sense that when the two did work together, in the needs assessment component, they were more aligned in which ones were showing up on their separate documents. This did not translate to the implementation strategies, and I think that's an important and interesting point. When they're looking at the same community and working together, though, they are seeing the same needs in that community. Interestingly, rural hospitals, or hospitals, I should say, that operate in counties classified as rural, were more likely to align with the local health department. Larger hospitals, conversely, were less likely to be in alignment with their local health department. Some of this could be about the market makeup. There are more health organizations, maybe to take different perspectives or divide the load. Rural hospitals, from a resource perspective, likely rely heavily on local health departments and others in the community for partnership. Our team's seen this in other work that we've done, that partnership is really important in rural healthcare.
Well, I want to learn a little bit more about sort of the therefore. How do we improve collaboration, and what do we do with this when there is and isn't alignment? We'll cover some of those topics after we take a short break. And we're back. I'm speaking with Dr. Cory Cronin about alignment between community health assessments conducted by public health agencies and by hospitals, focusing on Ohio, although also bringing in some nice national context on these issues. We've spent a lot of time in our conversation sort of trying to understand the degree of alignment and a little bit about where we're likely to see it and where we aren't. And I want to turn now to sort of the question of, well, what do we do with this? The whole premise here is that coordination, cooperation, synchronizing the timing would facilitate the kinds of community level approaches that would bring in the different resources that these two sectors have and help identify needs that maybe aren't being met, and again, joint efforts to try to respond to them. So before the break, we talked a little bit about how in some communities and for some hospitals, you are less likely to see alignment. But you began that answer by talking about gaining community input. And so I am curious. I've really been focused in our conversation so far on sort of the output. What are the elements and where do they align? So I'm hoping you can now turn back a little bit to where you were a moment ago and focus a little bit more on the inputs. If we're going to collaborate, it's not a matter of taking two documents, sitting down and reading them and saying, let's collaborate. It's starting much earlier in the process. And what did you see in that regard?
Yeah, the role of collaboration could be a powerful one. As I said before, I think that these two entities are really seen as leaders of health in their communities. And the idea that they have similar requirements, it makes a lot of sense that they would formally work together to do this on the assessment part of things. Same community, focused on improving health, and that they would share resources and come together. But what's interesting is that we keep in mind the different perspectives and potentially even goals. While improved health is a goal, there certainly are different systems at play for each of these types of organizations. I actually think that would be a strength in performing something like a health needs assessment. And so probably both organizations, if given this task, would take an approach of looking at very similar epidemiological data, for example. But you just mentioned community input. And this is one place that I think organizations could learn from each other in doing this process, or even learn from hearing each other's views on where to get that type of input, who to invite to the table, and how to process that type of information. And I think those are some of the goals that Ohio and other states are looking for, is similar but different perspectives, strengthening each other, and maybe taking a broader view of defining community and health needs overall.
So I like that framing, and it makes me then want to ask about sort of what you do after you've aligned your inputs and agreed at some level on what the community needs are, acknowledging that these two institutions have their own ways of thinking about things. But then presumably you want to do something about it. You want to think about what your strategies are to address these needs. And is there anything that you're observing, or is there anything in the Ohio approach about alignment on strategies to address needs, or does the sort of the collaboration goal end at figuring out what the community needs are?
So I think this is an interesting part of this study that our team undertook, is where we see factors associated with alignment on identifying needs. Those same factors don't seem to be associated with where strategies are being undertaken.
So I'm gonna jump in right here, because like my head is exploding for a moment, and maybe the listeners are too. So what you're saying is the characteristics that lead to alignment on needs are not the same as the characteristics that lead to alignment on how to respond to the needs?
That's correct. We looked at that idea of formal collaboration before. So about a quarter of the hospitals in our study had written to formal collaboration on creating these documents. That was not associated with the needs, the domains that we looked at showing up in implementation strategies. And so to step back, you ask, what do we do with assessment? And that's important and interesting. And so the IRS regulations for hospitals don't stop at assessing the community's needs. They actually say there needs to be a prioritization process. And when things are prioritized, there needs to be implementation strategies created. Ways that hospitals can, again, through publicly available documents, communicate to the community and public at large what they believe they can do about these needs, what resources they have, and how they plan to address these needs. Something we hope would be revisited in that next cycle of documents, as far as have these things move things? Are we progressing? Are the same needs persistent? And so we didn't see alignment here to the degree we saw on identifying needs. And I think it's an important point, and I think it's the nuanced part of this conversation. We don't need to assess communities over and over by multiple organizations in the same time period. There is a good reason to assess communities over periods of time. Things could change. But when it comes to addressing needs, I do think there's strength in working together, but there's also an importance to recognize individual organizations' areas of strength and individual resources. And I actually think putting the exact same implementation plan from both organizations might mean fewer solutions for the community. Meaning, even if we want to take a similar or same health need, a health department might have a completely different approach to addressing that need than a hospital would. Or even if they're working together on addressing that need, they might have very separate roles. And I think that's actually very appropriate. And as we're looking to regulate this area more, Ohio and other states, I think the nuance is finding ways to collaborate that strengthen, but not lose local or even individual organization strengths in addressing or putting resources in the community to improve health?
So I have thought a lot in the past about the hospital side of this because, the requirement, we get a lot of papers at Health Affairs about analyzing what the what the hospital's health needs assessments are showing and the like. But what I think I'm hearing you say is you really do want alignment around assessment and engaging with communities, but then you actually want intentional divergence in the response to acknowledge the different roles and different strengths of these institutions. And as you said, in Ohio, you've made a clear statement that these are two critical local institutions that can promote health, but they're two critical institutions with very different assets. And so you certainly want to work together on how you're going to respond, but you don't want to lose the individuality and the strengths. In fact, you want to see those as complementary strengths and weaknesses so that you can overcome them. I think that's a really interesting way to move on this. Just as we finish, and forgive me if this is not a fair question to ask off the top of your head, or answer off. It's easy for me to ask off the top of my head, but maybe not so easy for you to answer off the top of your head. But I do know there are a handful of states that are trying to take sort of intentional approaches, saying we're not just going to treat these as two completely separate processes. We're going to step in and try to make sure that hospitals are, as you noted, in Ohio, looking at the state level, not just the county. Can you situate what you're studying here in Ohio in some other states' efforts, and whether you think we're starting to see an emerging set of lessons from a few different states about things that seem to work and things that don't? And boy, if you have some insights into that, I'd love to hear them.
Yeah, that's a great question, and one that we could probably do a whole other episode discussing, honestly. But yes, Ohio's not alone in these efforts. The requirement for health departments to seek accreditation and the way that with their deliberate action of putting these things on the same timeline, aligned for this type of collaboration is interesting, but it's not the only approach to this. So Maine, Massachusetts, New York, for example, are taking on their own efforts that either require or encourage greater collaboration and coordination on these types of documents. And ultimately, as we've talked in this conversation, their efforts to improve health. I'll use New York as an example. And where things sit today, I'm not sure that I can fully answer the question because, as many policy discussions go, I think we need time to document things. New York is one of the earlier in these efforts that do give us some time. And so, one thing that New York has done is have the hospitals and health departments choose a need to jointly address, and then put in plans together in ways that they're going to bring their strengths, their resources in addressing these needs. And so I think we are, at this time, having some early data come in from those different needs that were identified, those different needs that have these plans to be addressed. In all of this, though, where my mind goes in thinking about effectiveness, and that wasn't exactly your question, but I think there's some idea of effectiveness there. I really think we need to think about if we're looking to effectiveness. A lot of this is about process. Has the health needs assessment been done every 3 years? Was there a corresponding implementation plan? Are they publicly available? And those are the check boxes we're hitting for compliance. But the question is, and in all of this work, what's really been learned is what rich data is out there, but what a process it takes to synthesize and understand that, or even look at larger trends. It might be easy to look at an individual community or organization, but trying to synthesize across the state or larger can be very difficult. And so we probably need to look at better ways to measure where things are effective, where things have been tried, but lessons could be learned. And I really think there's a really fruitful path of research looking at implementation strategies and what organizations are doing for communities or targeted populations or specific areas of health needs, and then bringing in some idea of, are there outcomes that we can look at? Have circumstances improved for individuals or communities as a whole? But I think there's a lot of work still to do there, and this is laying a great groundwork of data and evidence, and maybe most important, ideas for others to pick up on as a starting point if they recognize the need in their community. What have others done who see a similar need like this?
Well, I think that's a great place for us to bring the conversation to an end. You've really walked us through from some quantitative analysis of alignment to a much more organic and complex notion of how do we turn these administrative processes, checkbox things, into something meaningful? And then how do we know if once they're turned into something meaningful, they actually improve the health of the community, which presumably is why we're doing all of this. And that is a complicated question, but you've really helped me understand the evolution from these sort of legal requirements that you prepare things to understanding what the implications are. So Dr. Cronin, thank you for explaining this to me and for the analysis you've done in Ohio, providing the context around the country and helping us think about how to make take most advantage of the work that's being done. Thank you for being my guest today on A Health Podyssey.
Thanks so much. I really appreciate it.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.